Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse et Transplantation, and the Österreichische Gesellschaft für Nephrologie, Marcus at Home welcomes Professor Fadi Fakhouri in Lausanne, Switzerland, with whom we would like to discuss atypical hemolytic uremic syndrome, or atypical aHUS. Dear Fadi, it's a pleasure for us to host you a second time in this year after our Vienna ERA meeting. Thanks again for joining us.
Thank you so much for the invitation. It's always a pleasure.
Dr. Fakhouri is Professor and Head of Service of Nephrology and Hypertension at the Faculty of Biology and Medicine at the University of Lausanne in Switzerland. He's an independent doctor on the Global aHUS Registry Scientific Advisory Board, which does research on the data collected by the Atypical aHUS Registry, and has taken part in the National Kidney Foundation Working Group on Atypical Hemolytic Uremic Syndrome. Professor Dr. Jan Menne is Chief Physician at the Klinikum Siloa, Department of Nephrology, Vascular Medicine and Rheumatology since April 2020. Before, he has been working as a consultant in the Medical School of Hannover. His research interests are all forms of thrombotic microangiopathies, diabetic nephropathy, and treatment-resistant hypertension. Professor Dr. Paul Brinkkötter is Deputy Director of the Second Department of Internal Medicine at the University Hospital of Cologne, as well as Professor of Medicine for Glomerular Research at the University of Cologne. His research also focuses on thrombotic microangiopathies, and he is the organizer of the annual TMA Symposium in Cologne.
Thank you for this kind invitation, and it's a pleasure to be here once again. So I'm going to share with you some thoughts about atypical aHUS. It's not going to be a revolution because a lot has been already said, but it is to fuel discussion with the two other experts and friends that have joined us today. So where do we stand with atypical aHUS? The first point is things may seem settled in the field of atypical aHUS, but a lot of points and issues still remain debated. The first is what is the optimal name for atypical aHUS? And there's an ongoing debate and discussion, including in the National Kidney Foundation and other organisms, including KDIGO, to define what is the optimal term we should use for TMAs and particularly different forms of hemolytic uremic syndrome. And then this stems also from the fact that the definition of thrombotic microangiopathy by itself is very wide in pathology terms, and thrombotic microangiopathy is one of the most frequent terms used by kidney pathologists, with the other term being lupus-like nephritis. And as you know, we have lived with the terms of typical, atypical, secondary aHUS, but they are not optimal because they do not refer to the underlying pathogenic mechanism. And there have been some potential alternatives proposed, including complement-mediated TMA or aHUS or renal TMA. And of course, as you all know, during the last 20 years, the major change in the field of TMA was the unraveling of underlying pathogenic mechanism, and thus the design of specific targeted therapies that have changed the picture for a lot of firms, but not all of them, for a lot of forms of TMA, including atypical aHUS. So a couple of years ago, we proposed the term of syndrome of renal TMA, including extra-renal manifestation, mechanism of anterior cell injury, and the fact whether this form of TMA is predominantly or partially dependent on complement activation, and how does it respond to complement blockade. This may be very philosophical discussion, but as you will see a little bit later, it has very important implication in the management of patients. So we all know this scheme of complement alternative pathway activation with C3b deposition, tagging the cell for destruction, and C5 activation, tagging inducing the lysis of the cell. So one step is tagging, the other step is destruction. And as you know, the protection of the tear cell is based on the removal of the tag. There is a little regulation at the level of C5 activation and the subsequent formation of the membrane attack complex. So you have MCP factor H that binds the tag, C3b, and factor I that cleaves C3b. And atypical aHUS is due to dysregulation of the C3 convertase. So we are a lot focused on C5 activation because it has changed the management of this disease, but it is not the main problem. The main problem is C3 convertase, alternative C3 convertase dysregulation. We know that C5 blockade is major treatment and the cornerstone treatment for atypical aHUS, but not C5A. In animal models, C5A does not answer the question of treatment. But one may question the relevance of targeting C3 convertase and restoring a normal activity of the alternative C3 convertase. And as you know, we have now inhibitors that target directly C3 convertase, and one may consider, for example, iptacopan as a factor B inhibitor as a potential treatment for atypical aHUS. And as you know, it is currently tested, but with some difficulties. The first is related to ethical issues to use something else than C5 inhibitor in patients with atypical aHUS where the drug is funded and available. So you have to go to countries where it is not available and where the global management and standard of management for aHUS and TMS in general is not similar to countries where C5 blockers are available. The second is, in contrast to PNH, it's going to be very hard to see an add-on effect of a blockade of the proximal pathway, let's say, compared to the terminal pathway, because as you know, the residual risk of end-stage kidney disease in patients with atypical aHUS with C5 blockade is around 10–15%. It's going to be hard, in contrast once again to PNH, to see an add-on effect of, for example, combining a proximal to a terminal inhibitor. So this is the story. I should start very frequently, but for once we have a very nice translational research in nephrology, starting with a very rare disease, a lot of research, and at the end, efficacious specific treatment that roughly have decreased the risk of end-stage kidney disease from 50–60% to around 10–15%. But one has to keep in mind that PNH in hematology and aHUS have opened the way for a new therapeutic class. And without eculizumab and without PNH and aHUS, we could not have had this new therapeutic class of complement inhibitors that is completely changing the approach of several kidney and extrarenal disease. And as you know, not only this drug, C5 blockers, have saved native kidney, that have opened the way for kidney transplantation for patients who were on dialysis and who have already lost probably 1, 2, 3 kidney graft due to recurrence of the disease. So prophylactic use of eculizumab and C5 blocker in patients at high risk of relapse, mainly factor H mutation variants carriers, C3, factor B, have changed our approach to renal transplantation in this. So now we are left with 2 phases that I would like to distinguish in the management of atypical aHUS. You have an induction phase and a maintenance phase, and each of them has distinct issues and distinct questions. In the induction phase, the main question is, how can I be sure I am dealing with atypical aHUS? And second, I need a drug that guarantees that complement blockade is rapidly efficient. So how do we diagnose today atypical aHUS in general complement-mediated TM? All biomarkers are not 100% reliable, including soluble C5b9. You may have full-blown atypical aHUS with a real pathogenic factor H mutation and still have normal soluble C5b9. C3 is the same. Half of the patients with factor H mutation have normal level of C3 during the acute phase. So it's not 100% reliable. So as you know, the tests have been developed using modified red blood cells, endothelial cells in culture, incubated with serum from patients with acute or phase of remission of TMA. And when you see a lot of deposition of C3c or C5b9 at the surface of the endothelial cells, you would suggest that this form of TMA is dependent on complement activation. However, these tests are not very easy to replicate. They have been initially proposed by the Italian group, which have also very frequently very good ideas. The Spanish group did not succeed to replicate it, so they moved from serum to plasma. They had to activate plasma with coagulation, a tricky business. And at the end, in my opinion, they are not ready, these tests are not ready to be implemented in clinical practice. And in a very provocative way, I would say, is complement activation always deleterious? And as we all know, complement activation occurs in different settings, including, I would dare to say, in some forms of TMA, like preeclampsia or HELP syndrome, or TMA-like disorders, and they are self-remitting usually. Here is an example. This is a Spanish group. They took serum plasma from patients with preeclampsia and HELP syndrome. And as you see, at the initial phase of the disease, you have deposition of complement at the surface of the anterior cells, but this deposition persists when the serum is drawn more than 40 days after the onset of preeclampsia, which means even when patients are in a total clinical remission, you still have some deposition of the complement. And this is, in my point of view, one of the arguments saying that one should be very careful in analyzing this test. So today, it remains a diagnosis of exclusion, atypical aHUS, unfortunately. So you have to go through different steps to exclude other forms of TMAs, and at the end, you are left with atypical aHUS. So on this slide, I try to summarize what I believe the minimal set of tests you need for the differential diagnosis of TMA in aHUS. As you see, very limited number of complement tests, C3, factor H, factor I. Because if you have acute kidney injury and TMA and low C3, low factor H, and or low factor I, well, it has to mean that complement is activation, that TMA is dependent on complement. Test for anti-factor H antibodies, and this is very important because it's going to lead the rest of the treatment. ADAMTS13 activity, and Paul is going to speak about it better than I do. As you know, we have available tests that can give you very rapid estimation, at least, of ADAMTS13 activity. PCR for toxin in the stool, plasma homocysteine, not to miss homocysteine deficiency, metabolism deficiency related TMA, and some tests for autoimmune disease, and increasingly recognized a form of renal TMA associated to monoclonal gammopathy, and that responds rather nicely to C5 blockade. And as you know, these tests are not always easily and rapidly available, and you have scores that have been developed, the plasmic score or the French score, that have been designed especially to rule in or to rule out TTP and ADAMTS13 deficiency. But this is the crucial point in the management of patients in this case. But the diagnosis of atypical aHUS remains a very difficult diagnosis. One major example is malignant hypertension. You may have essential hypertension complicated by malignant hypertension and TMA. On the other side, you may have truly complement-mediated atypical aHUS presenting with atypical aHUS. And the two pictures may be clinically similar, but on the pathophysiology basis are very complete. So we proposed on this slide with Véronique Samobaki a couple of years ago, some sort of arguments pro or con the fact that you are dealing with essential hypertension going malignant and leading to TMA rather than atypical aHUS. This has not been validated, but it gives some thought to some food for thought. So, differential diagnosis by exclusion, scores that may be used, and then globally you may have ADAMTS13 activity less than 10% or 5% or more than 10%. And this is the central point. And what we are experiencing currently, and I think Paul will discuss it better than I do, is a shift in the management of TMAs in adults, because in children, plasma exchange has virtually disappeared in the management of TMA. But in adults, we are living period where we are moving towards a plasma exchange-free management of TMA in adults. The only argument to use plasma exchange in this situation is not to miss ADAMTS13 deficiency associated TTP with all the morbidity and mortality associated to this severe disorder. In all other forms of TMA, except maybe anti-factor H associated aHUS, there is no hard proof showing any efficacy for plasma exchange. So, with the availability of caplacizumab, with the long-awaited Mayari studies that Paul will probably discuss or give us some results, we are moving for a plasma exchange-free management of TMA. If you have a high suspicion or proof of ADAMTS13 activity, probably you would go for caplacizumab, recombinant ADAMTS13, or rituximab, and if you have a high probability, because it remains a probability of atypical aHUS, in my point of view, when available, you should go for C5 blockade and not waste time by testing plasma exchange. And this is the whole story and picture of the management. And if in 10 days you don't have a normalization of platelet and an improvement in hemolysis, you should question the diagnosis of atypical aHUS. There's no dogma, and everybody has made mistakes with the diagnosis of atypical aHUS. The person that says that he or she did never misdiagnose atypical aHUS probably is not telling the false truth. So, and probably we are underusing kidney biopsy in this picture when platelet count can allow, and kidney biopsy will help essentially to rule out other diagnoses such as lupus, cryoglobulinemia, or other forms of TMS. Let's move to the maintenance phase, and where the question is, in what patient can I safely discontinue C5? There have been many prospective studies, retrospective studies. We did a prospective study in France a couple of years ago, and to make a long story short, when you have no complement gene variant detected, the risk of relapse after C5 discontinuation is below 5%. If you have a complement gene variant, the risk varies between 30 and 60% for the MCP and factor. And in this study, we identified with patients with pathogenic complement gene variant the fact that if the patient keeps a C5 benign level increased under eculizumab, the risk of relapse after discontinuation is higher than compared to a patient who completely normalizes soluble C5 benign under eculizumab. So we treat patients, let's say, for 6 months. We wait for genetics, and this is one of the crucial points currently in genetics is how do we classify complement gene variants? As you know, you have a lot of private labs and even academic labs that gives you whole exome, a whole genome, and they give you a list of variants. But to be honest, in my opinion, there are only 4 or 5 centers worldwide that can help us classify the complement gene variant because they have the expertise of complement biology and genetics. So let's say you have no complement gene variants, no pathogenic complement gene variants, I would suggest discontinuing C5 treatment. If you have complement gene variant, it's on a case-by-case discussion. Even for MCP, it should be discussed because we lived with the idea that MCP variant-associated aHUS has a good outcome despite repeated relapses, but we have seen more and more frequently adults accumulating since childhood relapses, and they end up with severe CKD. And once again, caution in case of severe CKD, because even if you have MCP mutation, once you relapse, you probably will have irreversible kidney damage that will push the patient towards end-stage kidney. I have only 2 more slides, 2-3 more slides, about the spectrum of complement-mediated TMA. How do we define? And when you cross the Atlantic, you have 2 distinct views of what we call atypical aHUS. In the US, they tend to include an atypical aHUS secondary form. drugs, malignancy, etc., autoimmune disease, where in most European countries it's more restrictive to purely primary. So if you want to assess the complement dependency of TMA, I have selected 4 arguments, criteria: frequency of rare pathogenic variants, biomarkers of complement activation with all the limitation, response to anti-C5 blockade, and relapse rate. And when you look to what we call secondary TMA, drug, cancer, autoimmune disease, infections, the frequency of rare pathogenic variant is very low, and the risk of relapse is very, very low. And response to anti-C5 is not as clear-cut as we see in primary pure atypical. So a couple of years ago, we proposed in a blood paper our own experience and our own opinion about the short-term use of C5 blockade in patients with secondary form. When you have SLE, antiphospholipid, and even dermatomyositis, where the complement involvement in the disease by itself is overwhelming, I think it is worthwhile to use short-term C5 blockade. This is also true for some drugs, like gemcitabine. In my experience, when you have a gemcitabine-induced aHUS that has no hematological remission, even 10, 15, 3 weeks after days or 3 weeks after discontinuation of the drug, I would consider short-term treatment with C5 blockade. So in conclusion, atypical aHUS was a therapeutic issue, and I'm becoming old enough to remember the period where we all treated TMAs. At that time, that was called aHUS/TTP with splenectomy, cyclophosphamide, plasma exchange, plasma infused, whatever. It has become now a diagnostic issue. We have an efficient treatment, but we still don't have a 100% reliable positive diagnostic test. But it has also become a semantic issue. What do we call atypical aHUS? Does gemcitabine-induced aHUS should be called atypical aHUS and should be treated like any other complement-mediated atypical aHUS? This is an ongoing discussion. And finally, targeted therapies with eculizumab, of course, but also we started with rituximab maybe 20 years ago, but then caplacizumab and ADAMTS13, recombinant ADAMTS13, are radically changing our approach to TMA. And I think sooner or later, we'll end up, when we can afford it, because the price is high, we'll end up with a plasma exchange-free management of TMAs in adults, including atypical aHUS. Thank you so much.
Thank you very much for this amazing and wholesome presentation on atypical aHUS. It was very wonderful. I learned a lot, and I'm very excited now to hear what our other 2 experts have to say on your presentation. I now invite Professor Brinkkötter to maybe comment on this presentation and explain his point of view.
Thank you, Sara. Fadi, it was fantastic, and I think you gave us a very, insightful but a very focused overview on our current thinking, how to diagnose and to treat aHUS. And I truly believe that the hunt for the biomarker that we have observed for more than 10, 15 years to diagnose aHUS will still be ongoing for the next 10 or 20 years. aHUS is not another form of TTP where we will have a good biomarker as we have when we talk about ADAMTS13 activity. So I think we have to learn to live with this certain level of uncertainty. And I think you made really clear that it's time means kidney function. And of course, we have to rule out a major differential diagnosis. So we cannot start on day 1 or 2, but we should aim for the first week. And I think this is a very important message. At that time, we will not have back the data from the genetic analyses, some electron microscopy studies when you think about renal pathology will still be pending. And maybe some complement analyses will not have been reported back. But still, we have to make the clinical decision at this point and initiate the treatment.
Totally. We should not waste a lot of time. I totally agree.
Right. And this is, I personally think, and this is maybe something we can discuss, how you deal with it. This is why I personally are still convinced that eculizumab in this initial period is a very good and very efficient drug to start the therapy. And this is probably an advantage over ravulizumab with its longer half-life.
I fully agree. I fully agree. I didn't discuss it in the slide because we did a paper with a group from Lille, Marie Frima, when we treated patients very quickly with eculizumab, especially in the case of very severe acute kidney injury. And then if it turns out to be stat, you stop very quickly. So you should start very quickly and accept the fact that you may be wrong. And this is why I would always start with short acting than long acting, because long acting will condemn you to have a complement blockade for at least 2 months when you can be wrong. I fully agree with you, Paul, fully.
This is the way we do it. And I think, so eculizumab still has already been, but still is a very efficient and a very potent complement inhibitor, and especially for the acute phase, our first choice.
What do you say about hospitals where maybe eculizumab is not available? What should these doctors do? And maybe also you can point out some of the diagnostic workup that may not be available in just how Professor Fakhouri explained, because some of the things even I don't have available in Vienna. So maybe you can touch upon that, what we should do in hospitals where this is not available.
I spoke too much. I'll let Paul discuss.
I mean, this is, of course, a very difficult question, and this has to be answered and addressed for each center and each, society or country or healthcare system specifically. I think in Western Europe, we are in the very lucky position that eculizumab is widely available. Maybe not within 24 hours, but I would say within a few days. And actually, this is the time it takes to make, to rule out the major differential diagnosis and to call it aHUS at the end of the day. So I think the point is you have to recognize thrombotic microangiopathies as such, start your workup, and while you're doing the workup, and once you have ruled out TTP and autoimmune diseases and major malignancies, this takes a day or two, maybe, right? You should think about, okay, could this be aHUS? And then start your logistic chain to make sure that you get access to the drug. Just, to avoid to get into some hurry because it's Friday afternoon, and then you have a long weekend, and then it's the next week before you can start the treatment. But having said that, if, for example, an earthquake happens, or you're really in a desperate situation somewhere out on an island, and there's no ferry that brings you back to the main country, then of course I think plasma exchange or plasma can help you. It's better than nothing, but it's not our first choice. I think this has to be very, very clear. Our first choice is complement inhibition. And this is why, I mean, Fadi, you pointed, or you touched on this. I think the time of plasma exchange is over. We have specific drugs.
A question I asked you half a year ago in our German language webinar on TTP. Shouldn't we take these 2 or 3 days that it usually takes to get some more information and to get orientated, really to contact the centers who have all this experience, and not keep these patients in our regional hospitals, but contact centers like, from a German perspective, you in Cologne, or Swiss perspective, you in Lausanne. So what would be ideas on this?
I think the awareness of atypical aHUS has greatly increased. And here in Switzerland, you have to have the approval of some qualified centers to start eculizumab. So the centers are contacted sooner or later to have the approval for the use of eculizumab. But time is very crucial in this situation. And but I think the awareness has greatly increased, and people contact qualified centers to have, at least in Switzerland, the approval for eculizumab. Now, I think what will change, going back to Sara's question, is that I agree with you. Even the minimal set of tests I showed is not available everywhere. But things are moving. And second, biosimilars are arriving for C5, for eculizumab at least, probably soon for ravulizumab, and they are still expensive, but they will ease a little bit the financial pressure and make it available worldwide, maybe not worldwide, but in an increasing number of countries. But this is still a big problem. I agree with you.
And may I come back to diagnostic approaches? So you suggested there's a number of at least 4 or 5 complement factors that we should measure. So in hospitals that are not really specialized, we generally have only access to C3 and C4, and all the rest has to be sent out. In an era of genetic testing, do we really need all these plasma levels, or should we discuss to go directly to genotyping?
Fully agree. Very good question. The problem is the very rapid sequencing is still going, processing, and standardization. I agree with you. But if you don't have a complement gene variant, you still lose C5 blocker, because we know that the efficiency of these blockers, I think it may be helpful when you have some hesitation about the diagnosis. It would be one helpful tool, but it will not solve all the problem, because if you don't have a variant, you will gonna still use. I think genetic is more useful for the duration of treatment. For starting, it may be helpful in some situation where you are not 100% sure, especially malignant hypertension. If you have malignant hypertension and the genetics gives you in 24 or 48 hours pathogenic factor H variant, yeah, it will help. But I will not put all our probability on genetics.
And if I may add, I think, Fadi, it will also help us to guide the treatment duration, or if you think about stopping complement inhibition at some point, it's always good to know whether there was some measurable levels of complement activation to begin with, to recognize a relapse early.
Fully agree. Fully agree. But in the acute phase, I think it's better to start on a clinical probability, reasonable clinical probability, because time is a big issue, and stop once, because when you start doing whole exome, especially in emergency, you're going to have a lot of genes outside the complement system that's going to pop up, including collagen 4 and all the stuff. I think in the acute phase is more clinical probability for stopping, but getting the results early for genetic will help you maybe stop earlier the treatment. I agree.
There was one discussion, of course, I do not completely agree with. And this was the one discussion that we just should abolish plasma exchange completely in patients with TMA. I mean, it's not that it's not helping at all. And not everyone needs, within the first 4 or 5 days already, a specific treatment of a complement inhibition. There's no data whatsoever that shows that it really changes when you start complement inhibition on day 1 compared. I doubt it that it's really, you shouldn't wait for more than 14 days. And if you have the feeling, you should start it within 7 days. But I cannot say that where it's a feeling that we started for plasma exchange for a few days, and this really changed the outcome drastically. It's something different in small kids. Of course, you started because you will not treat them with a plasma exchange. But still, plasma exchange also in TTP, in the majority of patients, is a very efficient treatment. And it's not that it's not working at all. So I wouldn't put the funeral on the plasma exchange already. I think it's too early to start.
This is not what we said, Jan.
We will answer later.
Right. This is not what we said. We said we have more specific approaches. So if you have
I know, but
both
still, it's
hand,
already the nail in the coffin and you're closing the coffin. I know, of course, these are big hammers you're using, and of course they're efficient, and I also believe in them, but still, I doubt it that we really have to start now with everyone straight away a specific treatment. At the end of the day, it would be also only feasible in very few hospitals, because otherwise you would have to transfer all the patients through all of Germany or Switzerland and so on to find to a house who has all these 2 medications available.
Yeah, but I think it's an important message that I mean, it's one thing to transfer patients, and this might be complicated, require a lot of logistics, but it's another thing to call your colleagues at specialized centers and get them involved and help you to direct your treatment. And this, I think, is something that we are already doing, but this is something where we have to still get better by reaching out, building our networks to support each other.
Yeah, we agree with you, Jan. We were discussing about an ideal world where all medication are available, already in use in the hospital, in the pharmacy, and very cheap. But I would counter argue that in atypical aHUS, I have no single proof that plasma exchange would change anything to the outcome. For TTP, we can discuss, but if
I have one patient that proves it. I can tell you, this was actually the first patient, and we included this patient in the New England article. And this is a patient who had lost 3 transplants within 1 month. He had no mutation at the time in 2009 when he was participating in the trial, and he had, of course, the most advanced genetic test of the time available. We transplanted him in January 2009. Within 6 weeks, he had aHUS relapse. We started to plasma exchange him, and we biopsied him all the time. Within 10 days, the histological signs of TMA were gone. So we did send him off. 2 weeks later, he came back. We biopsied him again. Again, we had TMA manifestation. We started plasma exchange. Within 2 weeks, it was gone. We did send him home. We did re-biopsied him. The biopsy showed no TMAs. We did send him home. After 4 weeks, he came back again. And this happened 3 times, and we said, this is no way we will do it. So we started him 3 times a week, plasma exchange. And at the time, we didn't know that he would start to participate in the trial. And in October 2029, he was started on eculizumab. And since then, he is on eculizumab and now actually ravulizumab. And what you could see then before, this creatinine was always fluctuating a lot. And this ravulizumab, eculizumab was really very soft, and there was not these kind of fluctuations. And also LDH and platelets were not always going up and down. So definitely eculizumab is more efficient than plasma exchange. But in this case, it was working. Without it, he would have probably lost the kidney before he would have been able to participate in the trial. And of course, as a small child, because he had a transplant when he was 2 transplants when he was 6 years old, and 1 transplant when he was 12 years old, they didn't do plasma exchange. And of course, we were interested, what is this mutation? And so we did send him to next generation sequencing in 2020. And actually it turned out, he had hoped that we would find something new. It wasn't. He had a complete exon deletion, heterozygote exon deletion of exon 19 to 22 on CFH. And of course, this explains it completely. So he had extremely severe heterozygous mutation in the CFH. And this you couldn't detect in Sanger sequencing because there was no point mutation. It was just something missing. And this is actually, I would say, it proves that plasma exchange is actually working, at least in some patients. It might not work in others. He would have lost it as he has lost all the other 3 kidneys.
And waiting treatment, yes. But if you had eculizumab from the beginning, you would have used eculizumab.
Of course, but you said it's not working.
Yeah,
I think in his case, it's working. I would say it was working.
Yeah, a lot of patients were dependent on plasma exchange, as you know, at that time. We kept them for years on plasma exchange. We are trying to save the kidneys, but
we saw it also in the biopsies. I mean, it was gone immediately. Yeah. Within 2 weeks after the patient was completely gone, and we did it actually. We took about 7 biopsies within 3 months in this kidney transplant because he always had a relapse, and then we biopsied before he discharged him. And they could always see it was already gone again. So this was actually quite interesting, and there you can see how quickly these genes are changing. Of course, eculizumab is much superior also in this patient, and even after now 15 years, his creatinine is still below 2, and he's only on 2 times 500 milligrams Celsat and 5 milligrams of steroids plus
and
eculizumab. And eculizumab. That's all. So actually, for 15 years, it's
Okay,
quite
we
a
will
good
allow
result.
you to do some plasma exchange from time to time in this case. You are allowed to do some
Yeah, you're allowed. Oh, I feel honored.
I think that's the time to change the topic. I would like to ask about TMA in pregnancy. Maybe Professor Fakhouri could start to elaborate. You did mention TMA and malignant hypertension, and there are definitely some diagnostic challenges when we have pregnant patients presenting with these symptoms. Maybe you can talk about differential diagnosis and how you would go about a pregnant patient.
Yeah, very good question. And it's the two settings where TMA differential is very difficult is malignant hypertension and pregnancy. And we set up a consensus group 3-4 years ago, and we tried to give some guidance for patients and clinicians in this situation who have TMA in pregnancy and postpartum. And one of the main messages was that one should keep in mind that preeclampsia and eclampsia are by far more frequent than TTP and aHUS. So you're going to try to identify 5% of cases that are related to TTP and aHUS compared to the vast majority of causes related to preeclampsia, eclampsia, and heart syndrome. And the other message is that we said that if you can afford waiting 24, 48 hours to see how hematological parameters and kidney parameters evolve spontaneously, refraining from plasma exchange or any active drug, because in most cases, you're going to have a spontaneous resolution. And this remains a very tricky situation. And for the same case, one clinician would start eculizumab, saying it is aHUS, when the other would say, no, it's just preeclampsia and we'll wait to see. And nobody knows. The second very important point to discuss the situation is, what about a future pregnancy in a patient who had a history of aHUS? And now we have data showing from Vienna, but also from the International Atypical Registry and the Vienna Registry, showing that pregnancy in this woman is not as catastrophic as we used to believe. So it's no more a contraindication. We have a treatment. We need a close monitoring, including the postpartum. And in this patient, probably clinical and subclinical CKD is more an issue for preeclampsia, prematurity, than relapse of aHUS. But as Paul said, we are going to stay for several decades without a positive diagnostic test. And we need it in general, but particularly in the setting of malignant hypertension and pregnancy.
Perfect, thank you. And then maybe leading up to my next question, what is the role of complement inhibition in secondary atypical aHUS?
Jan is the expert.
Professor Menne,
Secondary?
please enlighten us.
You mean secondary, but you mentioned it already during your talks about chemotherapy and so on. So
he's going to say it's plasma exchange, but we will listen.
But actually, that seems that has really no good evidence in the secondary. That's not actually working. This I would actually agree with. Of course, we have these kind of short cases. What has been I mentioned already in chemotherapy and so on. But and that's definitely something where you should consider, but only very brief treatment. We shouldn't discuss it always long term. Sometimes just a brief treatment is sufficient. Actually, pregnancy is also something where we can talk about it. We have seen it always directly after delivery. Directly after delivery, especially when they had emergency delivery and also
C-sections, right?
yeah, and also bleeding during the
vaginal bleeding, yeah.
Atonic bleeding. And if that atonic bleeding and so on, then you get actually also clinical-wise a TMA picture with an LDH above 2000, actually higher than during the normal TMA presentation. And in biopsy, you also see TMA. And there you can have, there's a big discussion. Is this a truly TMA? Actually, there's this publication by Fadi Fakhouri in Blood, where they say it's not a TMA and you shouldn't treat it at all. You should just wait and support it, and you shouldn't give them eculizumab because it's not a TMA. Actually, in Germany, we are the more cautious that we actually give eculizumab in this situation. And probably, but you should only give one dose of it because I could imagine that these patients would benefit from one dose because usually they recover quickly. But it could be by one dose they will have a better recovery. And at the end, or usually, of course, it's a young woman, then of course you can also perhaps save more for a long time. But this is something that is unclear. In Germany, because we collected the data in Germany from 3 sites, and there we use it. And of course, we cannot say if it was working, but a lot of people are doing it. So this is exactly the problem with all these kind of secondary aHUS. Is it now a true complement mediated dose, or is it only a bystander? And it's difficult. But we did it just recently in a patient, and mentions this also with antiphospholipid syndrome. The insurance came to us and told us, why have you done it? We will not pay you the eculizumab. So this is now just right now. It's we have now written a rebuttal because it just happened, but we don't know what will they tell us. But if we are unlucky, they will tell us it's not fair. You shouldn't have done it because it's antiphospholipid mediated TMA and you shouldn't have given it at all. Of course, then I mentioned all your guidelines and say, well, but there are a lot of experts who will say it's also TMA form, but this makes secondary TMA extremely difficult, or secondary aHUS extremely difficult in the differentiation process. And then, of course, the majority of these are malignant hypertension. Some people are saying that malignant hypertension is a secondary dose or a primary dose. And no one can prove it. There are some data that say a lot of people with malignant hypertension have genetic mutations in complement. And some even say it's about 50% of patients with malignant hypertension have a complement mutation. We have done it in all our patients, and we see it extremely seldom that they have it. And actually, we even treated some of these patients also with eculizumab. But at the end, these are very tricky decisions. I don't know how you treat these patients, Fadi, if you would ever give it or not at all.
Maybe Professor Brinkkötter would like to comment.
I fully agree with Jan, and I think what he describes is a vicious cycle, right? That we have certain situations where we have complement activation. There's no doubt that we do see complement activation, in these patients, after, emergency C-section with, severe bleedings, we do see complement activation. And I think the question is there any benefit in interfering with this activation loop by giving eculizumab, which is faster as compared to simply watch and wait for the natural response to happen, to occur. And at the end of the day, this is a question we cannot answer. We don't have good clinical studies to provide, the proof that the one approach is superior to the other. But I think the medical, the experience and the gut feeling, everybody can tell, some stories from patients where they said, hey, here it made a difference. And then, of course, it's the question of association and causality, which we cannot solve. But I can think of several cases where we had, complement activation, and at some point decided, okay, we interfere with this complement activation I'm talking about short time administration of maybe 1 or 2 doses of eculizumab, which was enough to basically rescue, kidney function to some extent. And I think this is the point. And this is a new way of thinking as compared to 10 years ago. And but this has evolved over the years. I think this is also reflected by the new idea not to talk about, secondary TMAs in general, but to be more specific. To say, okay, we have pregnancy-related TMAs, we have stem cell-related TMAs. So to be as specific as we can, because in some cases, it's vitamin deficiency, for example. And there, of course, the idea is you have to replenish vitamin B12 or folic acid or homocysteine to resolve the problem. And this is, of course, then, it all falls under the umbrella of secondary TMAs, but there the approach is totally different. So I'm very much in favor of these new guidelines or new nomenclature.
Coming back to hypertension and secondary TMA. So is this really an either-or question? So people either have malignant hypertension or what we used to call vascular nephropathy, or may there be just some gradual changes between people in whom complement has a more important role and others in whom complement may have a much smaller role, but not really this either-or idea?
In any malignant hypertension, I would not be surprised if you see some level of complement activation. Because if you sneeze, you probably will activate complement. What is in discussion and what Jan referred to is that some people say, well, in malignant hypertension, we have 50% of patients that have complement gene variant. Others, including me, say, well, they were undiagnosed atypical aHUS that presented with malignant hypertension. For example, if you have a 35-year-old lady with no medical history that presents with malignant hypertension and TMA and acute kidney injury, I would label her atypical aHUS, not malignant hypertension doing. It is more a play on the word than nothing else, in my opinion. But it is hard to say if you are dealing with patients with essential hypertension, going malignant and having TMA feature, or truly atypical aHUS. It's not easy. That's why we propose some clues, but I think, in my point of view, it's misleading to say, well, I had a patient, he was on dialysis, he or she was on dialysis with malignant hypertension, and I did genetic tests and I found the complement gene variant. Okay, but you should have maybe labeled the case as atypical aHUS from the beginning. And I think the misconception stems from this. How do you call this? Do you call it complement-mediated malignant hypertension or complement-mediated aHUS presenting with malignant hypertension? And that's not easy to differentiate from the other.
Thanks so much. I have one more question with regard to the future. So you introduced us to this concept of addressing C3 rather than C5. How much may this also affect the safety of these drugs, vaccination strategies, infection complications?
We now have, not me, but there is data and experience published in PNH patients with proximal inhibitors, sometimes in combination with C5. And hematologists are not very keen usually to antibiotic prophylaxis, and there is no added risk of infection. So I think it's not the infectious risk that would be a problem, because even in C3G, where patients have already telcet, corticoids, and sometimes cyclophosphamide, we have not seen very big complication with pegcetacoplan or iptacopan. The problem is, how do we show that is effective where you have an alternative that is widely that is funded? It's not be easy to prove that is efficacious. This is a problem. But I don't think infectious issues would be a problem. Probably in the maintenance phase, keeping a break on the C3 convertase maybe would be better than going for C5 activation. In the acute phase, I don't know. Maybe in the acute phase, you still need to block C5 at some point because you have already damage going. But in the maintenance phase, maybe just keeping a small inhibition by inhibiting factor B or CC on C3 convertase would be enough to maintain the remission. But it's going to be hard to prove, unfortunately.
So thanks so much. We would love to follow you for hours and hours, but we are aware of your time, and we will have Paul Brinkkötter back in a couple of weeks with the next episode, this time again on TTP. But before we invite all our German and hopefully also Austrian and Swiss colleagues to Berlin, and that's why we are also happy to have Professor Menne with us.
So I would cordially invite you to come to Berlin for the DGFN meeting. It starts at the beginning of October from the 2nd of October to the 5th of October. And actually the topic is called Zeitenwende. Why have we chosen this one? Because there's so much happening within the nephrology field. And it's not only medication-wise, but what is organization-wise? How do you organize also dialysis in future, perhaps also more personal dialysis that we will offer in Germany. So there's truly a lot of things happening. And I think the program and also the submission by the posters we had, there were really some outstanding poster submissions and abstract submissions also to the Congress. So I think that it will be a very entertaining program. And Professor Weimann-Menke, who is the co-chair with me together, we would cordially invite you and would be very pleased if you would come to Berlin. Also, we are trying something new with the program surrounding. So some music, some singing, some dancing. So if it works out or if it will get a huge laugh, I don't know. But hopefully it will be entertaining.
Wonderful. Thank you. That is a great conclusion to this episode. I want to thank all of our guests again, Professor Fakhouri, Professor Menne, Professor Brinkkötter. Thank you very much for joining us in this super interesting episode. And we would love to have you again soon here at Marcus at Home. Thank you.